Welcome to Plenary Section 6, a case session entitled Pulse and Close, Concomitant PVI plus LAA Closure. The case was recorded at Asklepios Clinic, Altona, Hamburg, and I'm delighted to be joined by operator Professor Christian-Hendrik Heeger. Also for this session, we are again joined by expert panelists, Matthew McCullough from Jacksonville and Andrea Sarkozy from Brussels. So without delay, I'll hand over to you, Christian, for taking us through this case.
Yeah, Devi, thank you very much for the invitation. I'm very honored to be part of RIO. It's great to be here, Rhythm Interventions Online. And my topic is pulse and close, concomitant PVI plus left atrial appendage closure. So we heard a lot of PFA today, so maybe I go through the slides. We know that's a non-thermal ablation modality and called reversible electroporation. It's a completely novel energy source, and all of us are very happy to use it in our clinical routine. PFA is extremely fast, so it takes, in just an example, it takes 2.5 seconds to isolate a pulmonary vein if you are lucky. And it's also very, very safe because it's tissue specific. So the energy of PFA is only injuring the heart tissue in the best cases, and not the esophagus, and also not nervous tissue. So this is the very specific and very special thing on pulse field ablation. So it's very, very safe. We have got excellent data from the Manifest 70 case study. So all the complications what we're fearing doesn't happening until now. So we haven't seen any esophagus events, no PV stenosis, and also no long-term phrenic nerve paralysis. Currently, there are two different strategies for treatment of atrial fibrillation. Of course, we have drugs to restore sinus rhythm, and also we have drugs to prevent ischemic embolism. But there are also interventional methods like pulmonary vein isolation and like LAA closure. And we could combine both of these strategies. If we combine rhythm control and stroke prevention, we can combine PVI and left atrial appendage closure in just one procedure. And what are the advantages of this strategy? So we could target both, because both targets are inside the left atrium, which are very close next to each other. It will be just one procedure to do PVI and left atrial appendage closure. It will limit the periprocedural risk. It can restore sinus rhythm and prevent stroke and bleeding in just one procedure, and limiting the duration of oral anticoagulation. The negative effects might be the reimbursement considerations. For example, in Germany, we are facing some problems here, but hopefully not in the future. And we could, of course, get some device-related complications depending on the order of the ablation strategy. So I asked the social media community with this poll, so what would be your approach for left atrial appendage closure and PVI if there are no economic issues? And as you see here, most of our colleagues said that they would do simultaneous PVI and left atrial appendage closure. So almost 60% of our colleagues said this option. So also for me, it's clear that we should combine both procedures. There are also some data available, but only until the option study, only some single center retrospective data, mainly on the Watchman device and mainly on thermal energy sources like RIO and radio frequency, but no PFA until now. So this is just a study on radio frequency ablation and Watchman, and I don't want to bother you with the numbers, but you see here that if we combine it in one procedure, we could reduce the risk of major bleeding, and we could also reduce the risk of stroke in our patients. And the same for the cryoballoon. Also here, study cryoballoon and Watchman implantation with a CHA2DS2-VASc score of 2.8 and Hess-Bled score of 3. And if we combine it, we can reduce the rate of bleeding and the rate of stroke just with one approach and one procedure. Of course, many of my colleagues already showed the option study. I think it's very important, and the results are excellent. So it's a comparison of oral anticoagulation with the left atrial appendage closure after AFib ablation, and the results were remarkable. The safety endpoint met superiority, so the risk of bleeding was much lower if we combine it, if we perform a Watchman in comparison to oral anticoagulation. And the efficacy endpoint was also reached with non-inferiority, so the rate of stroke was the same in both. However, only 40% of procedures have been performed concomitantly. So we need more data on this. So this is the approach. Cryo and left atrial appendage is safe and effective. The same is for radiofrequency. What's about PFA, pulse and close? We conducted the Concomitant study. It's a retrospective multi-center, and Devi is also part of it. We're aiming to get 15 centers of this approach, power pulse and Watchman, but we will see. The results are not there yet, but in the future, hopefully. Okay, now we're coming to the life in the box case. So we performed a power pulse PVI procedure and the left atrial appendage closure procedure. Case presentation, of course, it's a 67-year-old male patient with persistent atrial fibrillation. CHEST bar score was 4. He had prior gastrointestinal bleeding, and we scheduled this patient for PVI plus left atrial appendage closure. After the procedure, we kept him on oral anticoagulation for 2 months, and we switched to ASA afterwards, and we had no antiarrhythmic therapy after 3 months. But let's start with the case. So that's the case presentation. That's my team. And of course, we do all of our procedures ultrasound guided. And I do these approaches with power pulse just with one ultrasound guided femoral vein puncture, one sheath, and only one catheter. So it's very, very smooth and very comfortable approach. So we always deploy a vascular closure system in these patients. In this case, it was a Abbott PairClose Pro style device, and then we perform the whole procedure just via one single puncture and one single hole. So now I deploy the system. It's a very convenient approach, and now I'm positioning the transeptal sheath, and you will see the echo images very soon. It's a bit fast forward. Usually I'm not that fast. And yeah, so this is the transeptal puncture. Of course, if we have a TE probe in, then it's a very safe and convenient approach. You see here the tenting of the fossa ovalis. I'm already left. And now usually I give some contrast to be sure that I'm in the left atrium, as you see here. And then I advance the sheath to the left atrium. And in this approach, in this procedure, we started with the PVI procedure. So I performed angiography of the right veins and also of the left veins. Left superior vein is here. Then I checked the left inferior vein. It was very, very far down in the bottom. Then we did the sizing. So we do the sizing prior the PVI to be sure that we not measuring any edema of the ridge. So the sizing was about 17 to 19 millimeters for the left atrial appendage landing zone. And we will do a sizing later on, and you will see that there's some edema. So now we change the SL1 sheath to a Farah drive sheath, and I place this in the left superior vein. This is a sheath of 16.8 French. That's the Farah wave catheter. Usually I take the 31 millimeter system only in very large atriums. Sometimes I decide to use 35, but usually I go to 31 millimeters. So that's the Farah wave device. So now let's start. It's a bit fast forward. I start in the left superior vein with a basket. And now you see the first application. And already it's always difficult to say that the vein is isolated because this is mostly not true. So the area where we ablate is already isolated and ablated, but maybe the vein is still open. That's why we do a rotation of the basket. And then we do 2 further applications on the vane in the basket position. And then I switch to the flower position after in total 4 baskets. Now it's the flower. And again, here we do 2 applications. Then we move the flower and do another 2 applications. And then we go for the next vane, which was the left inferior PV. And as you see here, we start with a basket position. Again, 4 times. And then we go for the flower. And usually after ablating the left veins, as you see here, I move the whole sheath and the system with the flower to the right veins. Here, you see we did a 3D TE, and it's very nice to see the flower at the left inferior vein. And yeah, I like these images very much because you can see what you're doing here. Yeah. And then we will move for the right inferior vein very soon. Yeah, this was the last application. So now we are already at the right inferior vein. Of course, we start with the basket position. And then we will switch for the flower. I think I do these approaches pretty much the same like everyone is doing. It's the recommended approach: 4 applications basket, 4 applications flowers, and it is for each vein. Now you see it's the basket is at the right superior vein. Again, we will perform 4 applications, basket and flower, and then we are done. So these are the last applications. So if we did this, I place the wire in the left superior vein. And then we will switch for the watchman sheath. It's a 14 French sheath. Usually in the beginning, I thought about there might be some bleeding because we switched from 16.8 French to just 14 French. But from my experience, it's not a problem. So there might be very tiny bleeding, but usually there's nothing. You see that the wire is placed in the left superior vein. And now we go for the watchman sheath, the anterior curve, and place this to the left superior vein. And you see again, we did an angiography, but we did the sizing again just to check if there's any edema on the ridge. And in the beginning, it was 17 and 19. As I said, 17 millimeters. The target, the landing zone, and now after the procedure it's much smaller. The size was just 14 millimeters now, so it's a bit smaller, most likely because due to some edema of the ridge area. And that's why we always perform the sizing, of course, prior the PVI and not after the PVI. You see the angiography here. I still do angios because I think it's an additional orientation. We decided to use 24 millimeter Watchman flex device. You see the flex ball here inside the orifice of the left atrial appendage. And then we slightly move it forward to get to the landing zone. And then I pull back the sheath and place the 24 millimeter Watchman device in the correct position. Slightly more deep into the left atrial appendage. We do the measurements now, and now you will see that I move the sheath back and place the Watchman in the correct position. Yeah. Now it's already open. I hold the sheath and the Watchman in this position. Of course, afterwards we perform a tuck test. I think it's a nice result. It's completely sealed. You see it also in the 3D. we do the tuck test. And then sometimes I do another angiography. And after tuck test, angiography, and another measurement of the compression of the device, we remove the wire, and then we get the sheath to the right atrium. Yeah, compression of 20 millimeters. And now I relieve the Watchman device and pull the sheath back to the right atrium. Yeah, that's the final result. I think it's quite good. And again, a 3D image of the Watchman device in the left atrial appendage. And now you saw this approach with a single sheath. And now I put the sheath back. And because I placed the ProStyle device via the procedure, I just get the suture done, and then I cut it off, and you see that's the final result. So it's a very smooth, easy procedure. Thank you very much. And now I will finish my talk. So our learning aspects were that PVI and left atrial appendage closure is feasible even with only one sheath. In our opinion, we should do PVI first and left atrial appendage closure second. We had some edema on the ridge, so that's why we do the measurements prior PVI. And I would like to conclude: pulse and close, concomitant PVI plus left atrial appendage closure. PFA is a novel energy source for safe, effective, simple, and fast PVI procedures. The option trial showed us excellent results for left atrial appendage closure after PVI, but only 40% were concomitant. It's very, in my opinion, reasonable to combine two procedures within the left atrial appendage. We can restore sinus rhythm and prevent stroke and bleeding with just one approach and one procedure. Our Coconut study will perform a retrospective analysis of PFA and left atrial appendage closure, as we see here. And we will get about 60-80 patients from all over the world, and we can get a nice analysis on this topic. So here are my contacts. So if you like to be part of Coconut or just contact me, please write me an email or text me. And I'm open for questions, and thank you again for the invitation.
Well, thank you, Christian, for that very, very seamless case. And it is, it's our pleasure to be part of the Coconut registry as well. So looking forward to contributing patients into the registry. Just to kind of take a minute and go step by step, we did see cases today as live cases with the concomitant procedures. And, every operator has another way of doing it. We just saw a case from Julian where they did the appendage closure first and then followed it with the ablation. And your recommendation was more towards doing the ablation first and then the appendage closure, which I agree that I think that's kind of how I do things as well. But having said that, want to start off with just some of the procedural aspects because, I saw that you are doing your transeptal under TE guidance. And are you assessing doing any kind of pre-procedural planning before you do these concomitant procedures? When you're assessing what size of the device, but also where the transeptal needs to be.
Yeah, exactly. So usually we do CT scan prior the procedure to check the size of the left atrial appendage. But in my experience, it's nice to have a CT scan, but I do the measurements just directly before the procedure, or just directly before placing the appendage closure device. Because sometimes, depending on the patient's fluid level and the situation, it might be different. So it's nice to know about the size and the form of the appendage, but I think it's better to do just directly before placement of the Watchman another analysis. So that's convenient for me. And
Andreas,
how often the the position of the transeptal puncture. I think the Farah pulse device is very forgiving for this, for the position of the transeptal puncture, but maybe not the left atrial appendage closure procedure. So we have to be very precise, and this is quite easy if you use TE probe for this.
Yeah, Andrea, what are your thoughts on the indications for concomitant procedure now, especially with the results of the option trial that just got presented?
I think the time has come to when we select the right patients with high risk of stroke and especially with previous bleeding. I mean, that's how it's our reimbursement is currently, so above a CHAS factor of 3 or equal. Now, I think, so my thoughts were when I was watching this case, I would like to just have 3 points I was thinking about, it came up to my mind. So the first one is that I was thinking when you do a single puncture parapulse procedure, sometimes we have a very long asystole. I was wondering that in routine, do you give atropine, or it just, how do you solve this problem? The second one was that we kind of like to, for example, there are some predilection of some places where we see more frequently reconnections, for example, on the left side between the on the left side, the left superior pulmonary vein and the roof. So we are a little bit liberal, giving more application. What's your idea about that? And the last one, I was just thinking, if you do the sizing, okay, that solves the problem of the edema on one side. But of course, I was wondering about the leak, because if you don't see leak, but when the edema goes away, do you need to do again a TE on these patients, or just how do we handle this?
Very good questions. So first of all, of course, in the beginning, we saw a lot of asystole in these patients because of very strong vagal reaction. Since then, we always give atropine, 1 milligram of atropine. So when I give heparin to my patients, I always give atropine together. So then I won't forget it. Concerning the strategy of ablation, so usually I do the 32 applications. So I do a very precise approach. So I do everything the same every time. So it's very standardized. I think if you stick on the protocol with basket movement, flower movement, then we can achieve a very high level of durable isolated veins. And concerning the last question, I forgot it. I'm sorry.
I thought so. It was the leak. If you do first the PVI because of the edema, then you don't see the leak at the end. I thought, do we need to do so? How do you solve that?
Yeah, it's a good point. So before we switch to aspirin after 2 months, we do a TE to check if there are any gaps. This is a very standardized approach here. So, and I haven't done a lot of these concomitant procedures, so I cannot tell you a lot of my experience. But hopefully, if we get the coconut data, we will tell you more of this.
Now, what are your thoughts on the post regimen, drug regimen for these patients, especially from an anticoagulation standpoint? You know, what are you doing now with your patients? Are you keeping them on 1, 2, 3 months? What's your follow-up strategy on these patients?
Yeah, so we stay on the guidelines. So we put them on oral anticoagulation for 2 months. And then we would do a TE to check if the occluder device is in a good position, and also if there are any gaps or leakages. And if there's no, then we will switch to aspirin.
And when is the imaging that's usually done? Is that the 6-week imaging with the TE or CT?
Yeah, no, just TE probe.
TE, okay. So there's a question from the audience on what's the distribution of imaging, TE versus ICE in these cases. Obviously, you showed a single axis technique. which is with TE. We're used to using ice for our PFA cases. And I mean, I don't think I can move catheters around the heart without ice. I mean, gotten spoiled over years. So, when you think about that, what is the practice in Europe currently for use of TE versus ice for these procedures?
Yeah, so there are some centers in Europe who use also ice. So I know a guy from Poland, and he's using a lot of ice. But in Germany, I think there's only one center which is using ice, and usually we don't use any ice because there's no reimbursement for this. Sadly, to be honest, because I would love to use it. Currently, the situation is that we use TE for every left atrial appendage closure procedures for guidance, but no ice. And I know that you love ice, and
No. I mean, I will tell you that I use a mix of TE and ice. It's just the simplicity of if there is already ice, being used for PFA, and I put the ice in the left atrium for my PFA, so it only makes sense to use it. But there's always pluses and pros and cons for it. What ice catheter do you use if you're doing it that way? And so there's a lot of other questions, like you said, have to be answered. And I think it's upon us to make sure that we collect the data prospectively, whether through registries or however it is, and know what is the right thing to do. I think we are entering a new field, right, with doing multiple things. And I think there's so much more to learn before we kind of jump straight into it. So I think I like the idea that we have the flexibility and the option of doing these procedures concomitantly and know that it can be done safely and effectively. But I think we still have to know what the long-term implications are, especially in Andrea's question on leaks. We did see an 80%, we only saw 80% complete closure in option. And so those are questions that I think we have to address and learn together as a team for that matter. And we do pre-procedural planning as well. But I do a CT and measure for before, but it's always interesting to see, right? When you put that device in after, the device is so overcompressed because you've sized it to the previous anatomy. And so we're super, we're just starting to watch and follow these patients more closely. And hopefully we'll have more data. Any final thoughts, Andrea, before we're almost at the time to end the session? So any final thoughts?
No, I think you summarized it very nicely. I learned a lot in this session, and I congratulate Christian for the very nice and very smooth case. He made it look very easy.
Yeah. Thank you, Christian, for that incredible case, and made it look very seamless and a single catheter approach for a concomitant procedure. Nicely done. So thank you for joining us. And thank you, Andrea, for joining us as a panelist as well. There is still more to come on day one of RIO 24. So stay tuned and stay with us again.
Thank you.